Okay, good morning everyone. Firstly, thanks to Adil and the rest of the faculty for inviting me to speak today, and it's nice to be able to kind of represent the physio community along with Darren here as well. So my brief for this initial session is to talk about anatomy and epidemiology of meniscal injuries. So we'll keep it quite tight around those areas, but I'd like to just kind of cover towards the end a little bit about the prevalence of surgical intervention for these lesions, and then pose a question to the audience that might just stimulate a bit of discussion in the Meet the Expert session a little bit later on. Okay. So in terms of the anatomy, once thought to be structures that were of little relevance within the knee, now known to be highly important in terms of the structural stability of the knee. They're made up of fibrocartilage, originating a Latin term, meniscus, but originally from the Greek term meniscos. Okay, well, most good things come from Greece, but I'd be biased. In terms of kind of the shape, they are kind of crescent shaped on the whole, made of kind of 70% type 1 collagen fibres. The medial meniscus does kind of blend in with the medial collateral ligament. It's not as mobile as the lateral meniscus, and that inability to be as mobile may be a factor in why we see increased risk of injury affecting the medial meniscus there. Insertion points at both the anterior and posterior horn of the meniscus act as anchors to the bony surface, the tibial plateau, and essentially the main function is to increase that congruency of the femoral condyles on the tibial plateau and act as a restraint almost to excessive translation. It's almost helping the cruciate ligaments in terms of their function. Okay. In terms of vascularity, we kind of believe them to have either a red zone towards the outer third of the meniscus, which has a blood supply and more likely a potential for healing. So in terms of decision making, that's important to classify where the meniscal tear is and whether that may be appropriate to maybe surgical repair or given more time for conservative intervention. If it's more on the inner, middle and inner third, we think it's more of a white zone, so less of a blood supply, so receives its nutrients from the synovial fluid. Okay? So that's an important consideration to consider. Is it in the red zone? Is it in the white zone? Typically we'll see the pathology within the posterior horns of the meniscus. And quite often we'll see this pathology alongside, certainly the traumatic incidents, alongside an ACL rupture. Okay. We typically see kind of two types, so we'll have the kind of traumatic onset, which is the younger population, that may or may not be associated with a ligamentous tear, but in the older population we have more degenerate meniscal tears, which come on at the insidious onset, and can be difficult to distinguish between an OA knee, especially in the absence of any trauma. So in terms of the incidence, as we can see there, with ACL injuries, we can expect to see between a 22 and 86% incidence rate, overall prevalence of 45% over the age of 50. And men are more likely to have bucket handle tears than women. However, women from the data are potentially more likely to have detachments of the meniscus. So some important kind of gender differences that might exist there. In terms of the kind of sports, so the theme of today, if we look at this kind of long-term study of the UEFA study, so this involved all the professional clubs participating in the Champions League over several years. So this was kind of an ongoing audit of evaluation of different injuries affecting professional footballers from the top European clubs. And in terms of meniscal injuries, over the period of time, it's about 3% of all injuries. So it is quite a small percentage, perhaps smaller than we would imagine, given we tend to associate these meniscal injuries with sports involving twisting, cutting type activities, which football clearly involves. If we look at a similar study, not as long in terms of duration and a smaller number of clubs, we can have a look at professional rugby, and this was from the American Journal of Sports Medicine. It's a little bit more dated, but an increased incidence of 6.2% of all injuries in professional rugby. So nearly double the amount would find in professional football. So in terms of the prevalence of meniscal pathology in asymptomatic athletes, so this particular study looked at the athletic population and found that actually those without any knee symptoms under an MRI scan found that actually nearly a third of them had meniscal tears, okay, which is quite a high prevalence, and increasingly now there's a trend, isn't there, in terms of investigating asymptomatic individuals with MRI scan and finding quite severe pathology maybe in the past would be a little bit more prone to jump in for an intervention, but bearing in mind what we're seeing in the asymptomatic individuals, we should really maybe be questioning how aggressive we are with some of our procedures. The second study, if we look at kind of the prevalence in more kind of a general population, certainly for those under 40, we're seeing a 4% prevalence of meniscal pathology, but over 40%, one-fifth will have meniscal pathology on MRI scan. So that should highlight to us that really we want to treat the person and not the scan. Okay. So if we look at rates of arthroscopic meniscal surgery over a long period up until 2016, we can see that a real kind of spike in activity around about 2006. If we look at the colours of the graphs, that is particularly prevalent in those with degenerate meniscal tears. We've started to kind of see a slight drop around about 2011, 2012, when some of the studies started to find that arthroscopic meniscal resection was no better than placebo surgery, but the rates were still very high. Whenever we see such a variation, so this is a map of CCG reported activity of arthroscopic meniscal surgery across the country. And as you can see there, so the white areas where there's low activity, the red areas high activity. Whenever I see maps like this with such a variance in terms of activity, I start to kind of question why that might be. Is it surgical preference? Are certain regions having more meniscal injuries than others? Probably not. So when practice is guided by surgical preference or activity levels, then for me it starts to raise some interesting questions. Is it evidence-based? Being one. So if we have a look at a global perspective, so England there is the blue line, the other kind of high activity country is Denmark, but again, significant variance in terms of the activity. Are the incidence of meniscal injuries that much lower in Scotland than they are in England? Probably not, so why so much variation? So whenever we read something in the Daily Mail, obviously we must kind of sit up and take notice, because it must be right, of course. And this kind of caught a few kind of headlines not too long ago, actually, after a study in the BMJ. So most kind of media outlets pick up on a BMJ type article, don't they? And then they sensationalise it and suggest that arthroscopic knee surgery is a waste of time. But actually, of course, because it's the Daily Mail, we should probably be a little bit mindful of fake news. Okay? But it does raise some interesting questions and does get the public perception of this procedure raised a little bit, which is not a bad thing, that we have these conversations and question what we do, which we should always do. And this was the particular study that they looked at there, which was discussed quite widely, and a number of letters to the editor of the BMJ follow this particular publication, which suggests largely that we should be looking at the evidence which strongly favours conservative management over arthroscopic surgery. And further research is unlikely to alter this recommendation, which is a real bold claim to make, that it's pointless researching this any further because this is where we are, which I think we should never get to that point, because I think for me research only reduces the uncertainty, it never really gives us an answer. But this is based on good quality, numerous articles and randomised controlled trials, so a high level of research. So we really should sit up and take notice when we see this kind of paper. So as a result of that, the orthopaedic community kind of looked at, actually we need to kind of have a bit of guidance here. So they produced the Basque study, which outlined the guidance of when actually in the green area arthroscopic surgery might be appropriate, which might be with a younger population with a discrete traumatic incident that gives rise to mechanical symptoms. That group actually would benefit. So we're starting with this kind of guidance to see certain subgroups where actually there's not one size fits all approach, and certain populations, certain subgroups with certain characteristics like mechanical symptoms would benefit from arthroscopic surgery. But on the whole, there's greater emphasis for a 3-month period of conservative management on the whole with most cases of meniscal pathology. So that was then kind of questioned again with the most recent paper, which was earlier this year in the British Journal of Sports Medicine. So another high impact journal that's actually looked at all of these nuances of, well, there are subgroups. There are younger patients that do better. There are patients with mechanical symptoms that do better. There are patients with traumatic symptoms that do better. But actually this kind of study actually looked at all those variables in their cohort of patients and found that those subgroups didn't seem to make a difference. So are we really on a bit of a wild goose chase here, looking for these subgroups when actually maybe they don't exist? And we should be be mindful of moving too fast and too far beyond the evidence in our approach to managing meniscal pathology. Okay. So more probably questions than answers from that perspective, but maybe a useful conversation topic to have in the kind of next few sessions. As I've said before, this certainly isn't the end of the topic. It is something that's going to rumble on. And the important thing for me is to not stop questioning what we do and why we do it. And do we have the evidence to support what we do? Let's keep asking the question. Thank you.